I think the next 2 sessions is going to be really for you. We're going to go down from the heaven of the high hopes to what we have today and what we can learn from each other's experience. So our first Ask Me Anything panel with clinicians are focusing on the symptoms of hemiplegic migraine and epilepsy. And what we have learned from the natural history study is that epilepsy and hemiplegic migraine tend to go together symptomatically in a child with missense mutation, and then a lot of they all have ataxia because the KECNA1A is highly expressed in cerebellum and hippocampus, but that ataxia seems to be somewhat separate. So that's why we have this movement disorder and ataxia are going to come after lunch. We have Elsa Rossignol, who's going to be coming up to talk about and answer questions about epilepsy, and Alexis and Irene to talk about hemiplegic migraine. And so you have actually brought us some questions already and have some videos. So Elsa has incorporated your questions and videos in her talk. So instead of separate talk followed by a question, we're going to kind of combine that for epilepsy. And for hemiplegic migraine, we'll have a short presentation followed by a question and answer session. And we would like to give as much time to you, so it's not going to be as much a didactic, but more of the what we call participant driven. So it will be more interactive session in the next 2 sessions. So we learned from natural history that epilepsy affects KECNA1A family about 50% of time, but it's my feeling, I don't know how many of family here have children with epilepsy. I do have a feeling that there will be more of you because epilepsy affects people dramatically, and it's very disruptive in my view. And while the KECNA1A condition should not be progressive per se, what we have seen is in those subpopulation, when they have intractable epilepsy, difficult to control seizures, they sometimes lose ground. And I think that's something we really wanted to focus on. And there are some signals now, and as you may be aware, we have new drugs coming almost every year or every few months, looking at the rare diseases, like for Dravet syndrome, for example, for SCN1A mutation. We have very specific drug designed for that condition. So epilepsy is it has a good marker, therefore it's attractive to the company. And so we have vamploramine specifically for Dravet syndrome, Lennox-Gastaut syndrome, the Epidiolex was specifically for Dravet syndrome and Lennox-Gastaut syndrome, tuberous sclerosis. So I think KECNA1A has potential to be part of that. And a good news is, at least for epilepsy and developmental and epileptic encephalopathy, we actually have a new way to join forces as what we call basket clinical trial, basket with all the developmental epileptic and encephalopathies. KECNA1A Foundation community can be part of that, and at least in clinical trial of epilepsy. So I think that's something that's coming very close to you, not to wait till there are 500 of you. I think it's something that can happen now in a basket clinical trial. So keep an eye on that opportunity, because the community has come together. You are present, and you are ready to enroll. I think that's something that can happen soon enough. So, Elsa, are you ready to talk about? And you can come up.
Okay. Thank Thank you. So it's really a huge pleasure to be here with you today. So I'm a pediatric neurologist in Montreal in Canada. I'm also a basic scientist, so I run a lab where we study the disease mechanisms of epilepsy with a major focus on CAC9-1A, and we now have good established models in mouse, and we're looking to therapies. But I do have a clinical task as well. So I have seen some patients with CAC9-1A, and I was asked by the foundation to provide a little bit of an overview. And of course, Dr. Koh is an expert as well, epileptologist, so we would both be able to answer your questions. Okay, so, the thank you is first, because really, we don't know that much about epilepsy and CAC9-1A disorders. What we know is thanks to you, to your families. So whatever, when we were asked a year ago to design clinical guidelines to treat epilepsy, I'm a scientist, and I was saying, well, I've seen a few patients, and you've seen a few patients. I think we don't have enough data to say anything, really. And so that's why it took us a little bit of time. The clinical guidelines are coming up, but with the National Natural History Evolution Study, we did get more information that makes me more comfortable telling you about what we actually know collectively, thanks to you. Of course, I want to thank the foundation for allowing us to do all of what we're doing collectively. And most importantly for this talk, so we received this list of questions. I think there were 40 questions related to epilepsy. I tried to structure my talk around all of those questions, and I've looked, I think there were something like 35 videos. I've looked at all of the videos. I've picked up only a few. If I have not answered your question during my talk, please write an email. It will be my pleasure to answer. So how frequent is epilepsy in CAC9-1A mutations? Bottom line is that it's not that clear, but we are starting to have more information. Of course, initially, the first patients with epilepsy and CAC9-1A mutations that were described were part of epilepsy clinics. So it was hard to know what was really the prevalence in a larger population. And if we take large populations of children with developmental delay and epilepsy, about 1% of them have a mutation that will explain their epilepsy and is linked to CAC9-1A. So it is up there in one of those important genes. If we talk of Dravet and SCN1A, it's usually 2-3%. So 1% is kind of important in the field. So I agree with what was said before that it may interest pharma. Now, in the natural history study, we've heard that about 50% of patients that filled out the questionnaires reported having epilepsy. However, I would say I think this is a little bit biased. So people that will go to the trouble of filling questionnaires are usually those that are affected by more severe disease. So overall, the prevalence is probably lower than this. When we look at patients that have a diagnosis of episodic ataxia, we say about 7 to 10% develop epilepsy. And when we look at patients with familial hemiplegic migraine, there can be coexisting epilepsy, but also after a severe event, a stroke-like episode with brain edema following a trauma, for instance, there can be some brain injury, and that will increase the risk of epilepsy afterwards. So there is often coexistence between those disorders. Now, I want to point out that there's a large inter-individual variability, so even patients that have the same mutation may present differently over the course of the year or of the disease, and so using only the genetic data, it's often hard to really predict for this particular kid what's the risk of having epilepsy. I just want to show a first cohort that we had published, years ago now. That was the first real demonstration of epilepsy with developmental delay in children with CAC9-1A variants. And I was fortunate at that time to meet these families. So these were inherited dominant variants. Those were nonsense variants. So if we go back to the first talk of today, those were all variants where one of the copy of the gene was deleted or truncated, and so was absent. So, and in those cohorts, because I was able to see all of the family members that also carried the variants, I color-coded symptoms here, but basically what we have in the cohort is about 25% of patients had epilepsy, those are the green dots. 29% had febrile seizures, so the red dots, meaning that they had seizures only in certain circumstances with fever, so they did not develop epilepsy, but there is a tendency for seizures with fever in this disorder. And then in yellow, we had the neurocognitive disorders, suggesting that in the cohort, there was a range, but patients had a higher rate of learning disability, ADHD, and that could range up to intellectual deficiency. And a third of the children in the cohort had autism spectrum disorder. Now, all of them had some degree of cerebellar symptom. These are loss of function variants, and so the cerebellar disorder was very intermittent ataxia. Often the parents didn't know that that's what their symptoms were, and so I made a few diagnoses on the spot, talking to families, because these could occur for 5 minutes, 2 times a year. So they can be very mild, unstable gait with triggers, and all of the families had, the patients that I examined had downbeat nystagmus. And so if I do this, yes, you could play the video for me. So these are in 2 children, the 2 brothers and sisters. So looking down, you can see this going down nystagmus, and you'll see it in the other child a little bit, yeah. So as they grow, other ophthalmologic symptoms appear as they grow older, and then we have all sorts of other symptoms. But what I want to show here is that if you take a group of patients with, loss of function variants, some patients actually don't have much symptoms. They may not even know that they have a disease. And then in the cohort, with the same variant in the same family, you may have different expression. And that probably reflects other factors in the genome that are modifiers of the outcome. And so it's a little bit difficult to know for one particular variant if the child will have epilepsy. But we know that there's an increased risk. So then the question that arose was, what type of seizures, what are seizures in CAC9-1A, and what type of seizures are reported? And so for that is really where I felt we didn't have enough information, but we were lucky to participate and to get information from the registry. So when we looked, that was a year ago, and we had 48 patients who declared having epilepsy in the cohort at that time. And we also partnered with colleagues in Italy with multiple centers, and these families were not able to fill the questionnaire online due to language barriers, so we had clinicians fill out the questionnaires with the families. So we have 68 patients in this cohort. This is not yet published, but we're submitting the data in a week. Okay, so overall in this cohort, the mean age of onset was anywhere between 0 and 6 years, with a mean age around 7 months. And the seizure types were quite variable. For each single individual, half of the patients reported having more than one seizure type. So usually individuals will have 1 and 2 and 3 seizure types. You can recognize these seizures, and as they occur over the time, those seizures don't change that much, but they may have different types of seizures in the same patients. And so the most frequent seizure types were the focal aware seizures. I will show you videos of this. Generalized tonic-clonic seizures, absence seizures, focal seizures with impaired awareness, and I will show you videos of this, as well as atonic seizures and infantile spasms. And then the status epilepticus. Status is always a big concern. So those are seizures that last more than half an hour. They do occur. Some children with some types of mutations seem to have recurrent status epilepticus, and this can be worrisome. So we are trying to combine medication to reduce the risk of that and to have emergency medication at home to intervene when you do have a long seizure and to go quickly to the ER to try to get the seizure interrupted. Overall, it seems that the seizures improve with age, and so this is still something that should bring some hope to families that are battling with this aspect of the disease. So I have now 2 slides that I typically use when I teach students about epilepsy, because I thought that those videos really capture the types of seizures that have been described, and then I will go to the videos provided by the community to illustrate some other aspects, because for some of them I didn't have a good video in the bunch that was submitted, okay? So the first time is an absence seizure, and so you could play the video here. Basically, the child is, and you can elicit them by hyperventilation, and so at some point he will stop doing his task. So there's an arrest of activity, and then you'll see myoclonus of the eyelids, as well as automatic movements of the mouth, like chewing movements, and then he comes back to baseline. In absence, you can have those movements of the mouth and eyes, or also you can have none of those movements. If you do have these movements, it makes it a little bit easier, but when you don't, what you really need to show is that there's a clear arrest of activity. It's on and off, usually lasts less than 10 seconds. It's very brief. And so if you touch the kid at the time where they have the absence, they won't be reacting to what you're doing. And then eventually they come back. And it's really an on and off. Usually they come back right to where they were, and they usually don't lose tonus at the same time as an absence. So this is a typical absence. And if we do an EEG during an absence, what we see, and I'll tell you more about EEGs later, but EEGs are very good for depicting this type of seizure. So you have this background rhythm, and then suddenly, boom, you have this discharge. And those are the spike wave that are generalized. And we will come back to this type of trace later. But this is typical for absence. And then as soon as it stops, you go back to the natural rhythms. Another type of seizure is myoclonus. I'll show you an example here that can be combined with absence. And so, I'm sorry about this. Let me go back. So if you can play the video, thank you. So the child is eating, and you'll see that he has movements, uncontrolled movements of his arms. Here you go, boom, boom, boom. A few of those. At the same time, in this particular video, the kid also has a little bit of hypotonia and also a loss of consciousness, maybe, or interrupted consciousness for a few seconds. You can have myoclonus that is not with an absence. You can have myoclonus that's isolated, and for that, we have very good video from the communities, and I will show you later some myoclonus without absence. Right, so if we do the EEG at the time of a myoclonus, we typically see these polyspikes on the EEG that interrupt the rhythm. Now, spasms usually occur in young kids before 6 months of age, and so you could play the video here for me. So typically, those will recur in a series, and it's abrupt contraction of the axial muscles and the legs, and sometimes the arms can be outgoing or ingoing, and so these are recurrent, and you'll have a few of them one after the other. You could stop the video here. So these events usually occur when a kid is falling asleep or waking up, so there are times in the day that are more prone to these spasms, and so when we have suspicion of this, an EEG can be very useful, and we do see major changes in the EEG. I'll show you later, but this is an abnormal background rhythm, and when you have the spasm, the activity just goes down suddenly, and so we can document it with an EEG. The last one in these more like general slides is the drop attacks or atonic seizures. So you could play the video here. So the child is doing physio, doing his usual activities, and you'll see that it suddenly just loses tone. There you go. Becomes very limp, and that's a few seconds. He will go right back up. After that, ready to go again, but these are atonic seizures. And so when you see the EEG of those, it also shows clear spikes. And so you can see here are normal background rhythms, and then you have these polyspikes. So here we go with the videos that you have all so generously provided, and I have a few disclaimers. For patients in the room or people that have not been exposed to epilepsy, some of the videos could be uncomfortable to watch. So if you don't feel you want to see them, you're welcome to step away, and I would fully understand that. I did choose videos that were provided by the families here. I'm a physician from Canada, so what I'm discussing today is not diagnostic. I'm not providing any diagnosis or therapeutic, recommendations for your children when I'm watching these videos, but these are really for teaching purposes with you. And for those on the Zoom, because these are videos provided by the community, please don't film or record these videos without the consent of the families. Okay, so one of the major types of seizures in epilepsy associated with Category 1A are those generalized tonic-clonic seizures. They can occur at various times. Sleep is a moment where they are more prone to occur, and waking up is a time, falling asleep or waking up is a time where we do see more of those. What you'll hear and see in this video is a child that clearly has a seizure. She's unconscious. She has tonic postures of the arms. You'll see clonic movements of the trunk. You'll see some clonic movement of an arm, and you'll see the rhythmic breathing pattern. So those are clear signs of seizures. Okay, So those are the more perhaps worrisome seizures. They can be short or long, and if that goes up for more than 5 minutes, then obviously you want to have a rescue med and go to the ER. We want to stop those within 30 minutes, as much as feasible, to prevent consequences on the brain. So another type of seizure that was reported often is myoclonic. So I showed you the myoclonic absence earlier in the video. You can have myoclonus that is without an absence, and you can have myoclonus that is with an absence. So it can be, you have different types. And myoclonus can also be, I showed you more the proximal ones, but what you'll see in these videos is more distal myoclonus. And the characteristics is a clonic seizure is usually very rhythmic, whereas myoclonus is a little bit more jerky and arrhythmic, but it's uncontrolled, it's involuntary, right, so let me show you the video. So you see those are more distal, so there are these little tremor-like contractions. It's not just a tremor because she does have clear contractions of the muscles, so it's not just a tremor that will occur when you're doing something. It's different. It's really uncontrolled, arrhythmic muscle contractions. Some myoclonic episodes can be non-epileptic, so an EEG will show you whether there's epilepsy with it. Some myoclonic events can come from the spinal cord. It may or may not change the therapy. We usually don't treat that much the non-cerebral myoclonus, except if they're really causing disruption, then some benzodiazepine can help even the spinal cord related myoclonus. Some medications can increase myoclonus. So if you have a child with epilepsy and the myoclonus starts showing up more, you can discuss with the epileptologist. Some of the medications could be just increasing these events. Now, we talked about focal seizures with impaired consciousness or focal impaired awareness seizures, and those were very frequent in the community. I'll show you a few examples of those. This example, the child has clearly an impaired consciousness, and you'll see forced eye deviation, and that's very typical when the focus comes from the frontal lobe, so the eyes will deviate. It can also be with some occipital lobe, but in this case, it's really frontal because at the same time, he has hemifacial myoclonus or clonus. And so that's the motor control of the face that's playing here and giving this seizure. So these are the muscle contractions that you can see, the eye deviation to the right, and he's clearly not aware of what's happening. You can see even the clonus at the tongue level. With seizures like this, you can have discoloration of the lips, and that can be worrisome, of course, to see. He will come back, and the coloration will come back very quickly, and soon he'll be just back to his usual. So please note also he has this chewy type of movements after that was part still of the seizure. Now the seizure is done, and you can see he's now back to being able to move consciously. Yes, so this cyanosis can be worrisome. You have to understand that it's a mechanism for the system to try to protect the brain. So the brain activity is abnormal during the seizure. The blood is going to the brain, not so much to the skin. So of course it's worrisome, but it's a good mechanism so that the skin is less important than the brain at that time, and the color will come back. Okay. Another type of focal seizure with altered consciousness, I want to just point again the forced eye deviation and rhythmic breathing, as well as the clonic right hand movements in this. So there's some motor component in this particular event here. So eye deviation, she's obviously not conscious, and she has these clonic movements of the mouth as well as the right arm. Okay, so these are the more tricky ones. So those are sometimes considered absence by families. They're not really absence, they're focal seizures with impaired consciousness or impaired awareness. In these two videos, the child you'll see has some partial interaction. So the altered consciousness can be variable. You can be partially interacting and then going out of it, so it can be fluctuating. What I thought was very consistent in both videos was the stereotypic lip movements and swallowing that are kind of uncontrolled, that typically signals temporal lobe seizures. So Dr. Koh, you're welcome to intervene if you disagree, would like to add something for these two videos that we haven't had time to chat about. So in this first kid here, you'll see that, she seems uncomfortable, you'll see during the video. Oh, and we don't have the sound. Of course, I asked to remove the sound, but her kid sister is running around and making sounds. She's kind of not really into it. I should have left the sound on for this. I don't know if we can still leave the sound on. Yeah. So she's not really reacting to what's happening. And you'll see that she feels uncomfortable as we go.
I know.
So you can have these worry, fear-like episodes, and some uncontrolled movements of the lips.
It'll be okay. It'll pass. It's okay. It'll pass, baby. Are you cold? Oh, your goosebumps.
So I don't know how usually she talks, but you may have altered speech during that as well. Something is frightening her. It's not really clear what's happening. And then at the end, you'll see more of the rhythmic movements of the mouth and
Feel good.
some swallowing that she doesn't seem to be controlling. So if these events were to recur often, and if there has been a doubt, video EEG should help document that these are probably seizures. Oh, we could stop that first video. I'm not sure how to do that. Sorry. Okay, I was too fast here. Okay, let me go back to this. Yeah, sorry.
Maybe this one. I agree with you. I think this is focal seizures. So when we talk about distinguishing between absence versus focal seizures, we call it staring spells. The absence are on and off, and they recover very quickly from the being kind of staring ahead, whereas this one definitely, not only she had kind of behavioral arrest, looking straight, but then just the postictal badness or confusion or fatigue. So that's what distinguishes focal seizure being a staring versus the absence.
Yeah. Thank you. Okay, and so the other child has also some of these swallowing and lip smacking that you'll see. So I thought they were kind of similar. So at the beginning, he's kind of playing with his mother, who's talking to him, and then he's kind of, fluctuatingly in, out. Now he's not reacting as much. She's talking to him. He's not really doing what he should be doing. Then he has these mouth movements with swallowing. It was brief, you have to know, but it is consistent, and it's similar a little bit to what the other patient had in terms of this uncontrolled swallowing and movements and blanking out. And at some point, he comes back more. And so these are long. They're like 20, 30 seconds. You didn't see the lip smacking. You want me to show it again? No? Okay. So, right. So once again, these could be, this I believe is also a focal focal seizure with impaired awareness. Okay, so then I have a few videos where the events to me were unclear, and that's because of I don't know these patients, I don't know the context. And one of the things when we receive videos, even for your physician, is really important to try, if you think these are absence or focal seizures with impaired awareness, to stimulate the patient. So just talking, saying, aha, hello, hello, is not enough. They may not be reacting. So you need to touch them. You need to really do deep stimulation so that we know if they're reactive or not. That will be very helpful. So in those two videos, for me it wasn't clear, but they could be, maybe not. I thought they perhaps were not, actually, because I didn't see any other signs. But other signs that you could look for as parents are autonomic signs, such as breathing irregularities, pupillary dilatation, heart rate that goes up. Those are associated autonomic signs that you could look for, and it's hard on a video to know. So the first patient, right, it's on the right. So she's, in the couch, and it's very hard to know if she's reacting or not. Maybe she's just, daydreaming. I don't know. So to be able to be more clear, it will be important to stimulate physically. And for the other child, so she is partly interacting with her environment. You'll see that she's going to be reaching out for something. She does look, perhaps slow, but I don't know how she is usually. One of the things I would say, though, is in children that have atypical neurodevelopment, sometimes they'll feel things in their body. They can feel pain, like, some reflux or constipation, or any physical manifestation can make them look in their world and uncomfortable. So you need to stimulate them to see if they're actually just paying attention to an internal sensation or if this is really an epileptic event. And once again, if there's doubt, an EEG will help, mostly. Now, last one is, for me, clearly not epileptic. That's head titubation. So it's a motor control issue with the neck. And so she's doing stuff, she's looking around, but it will keep on happening even while she's interacting. And this is more of a control, balance of the actual musculature control. So this is not epileptic. And if you were to stimulate, you would see that it's not. And this type of no-no oscillation is not typical of seizures. Okay. There are two videos that I thought were interesting. Apart from the fact that kids with neurodevelopmental atypias can be invested in other sensations and having these blanking stares, they can also be looking for stimulation. So you can have the head nodding, that is vestibular auto-stimulation. They can be looking at their fingers because that brings some kind of stimulation to the brain, and it can be pleasurable. And I think this is probably what's happening here. So you'll see that she's nodding from side to side. At some point, she'll be looking at her fingers, making things in space, and she seems interested with maybe the shadows and the stimulation that this provides. And interestingly, we have another video of the same patient in her carriage, and she's also doing stuff and looking at her fingers. So I think she's more doing these auto-stimulation events with the fingers. But if there is episodes where she's blanking, such as here, perhaps stimulating her would be helpful to try to parse out what's what. Okay, so those were my videos. Now, quickly on the EEG, there were a few questions. So is it useful, and why is it so hard to interpret? Well, usually I say that looking at EEGs is a bit like chiromancy or magic. So you need to be a real expert to know what you're looking for. Basically, what people need to learn first as electrophysiologists is to recognize what's normal and what are artifacts. And then you look for abnormality. And so yes, it can be variable in their interpretation. What we're looking at is really recording from various brain areas on the scalp, and we're depicting the difference in voltage between different leads, so FP2, F8 here, and you can see background rhythm and suddenly these spike wave discharges in an absence. So these are the normal rhythms that we observe in all children, in every human baseline. And so you can see how variable the EEG is, and it depends on sleep stage. So usually an adult will have these nice alpha rhythm when they're quiet and awake. But when we're feeling drowsy, such as now, you can have theta rhythms, and kids before 5 usually have theta rhythms. So it kind of is interrupted. It's a mix of rhythms. In sleep, you have these slower waves, delta waves. So when we talk of background slowing in the EEG, it could reflect the state. So if the child is very drowsy, that could be what we're observing. So what the EEG specialists are looking for are these clear epileptic activities. So those are activities that interrupt the background rhythm, such as spikes. So they're very tiny and very long, and they're very different from the background. Sharp are a little bit less sharp, less spiky, and they may be natural and physiological in some individuals. So they are not always signal epileptic activity. Then you have the spike wave, the polyspikes in a row like we saw in the myoclonus, and then a polyspike with a slow wave. So those are the type of events that electrophysiologists are looking for. But of course, with EEG, we're not doing, oh, zit, I did something wrong. Oh, yes. Okay, there we go. Okay, so we're not doing the EEG all the time. We're doing it at some point in the life of a kid for 20 minutes, right? So we may be missing activity. Here are typical activities published in children with CACNA1A, just to show you how different it can be. You have here these background slowing, so compared to the front electrodes, so that it's faster, you can see that these you have more delta and theta activity here. This is an activity with a lot of spike and waves, so that is clearly epileptic as well. You can have some background slowing here with spikes more in the temporal lobe, and you can have a more focal discharge here. And then I'm not seeing well with the screen, but you have multiple spikes on the other EEGs. So yes, yeah, 5 minutes. Right, and so these were 2 others published in the literature in patients that don't have epilepsy. So even in kids that have hemiplegic migraine, you can have epileptic discharge. It doesn't mean that you're epileptic. So how useful it is? Well, it reflects broad brain activities. It can miss seizure if you're doing the recording between seizures. For deep focus, so the temporal lobe ones, the one with swallowing, sometimes you'll miss the activity on the EEG because the focus of the epilepsy is too deep in the brain. So sometimes you need to repeat or do other means of recordings. Background slowing was a question, so it can reflect drowsiness, but also after a long stroke-like event with a hemiplegic migraine, if there is a part of the area of the brain that has been injured, yes, it will be slow. After a prolonged, like a status epilepticus, you'll have background slowing. That usually should resolve within 1 week or so, but kids that have a lot of them can have more generally a slowing of the background of the rhythms. It doesn't mean they're epileptic. Background rhythm slowing can just mean that the networks are functioning differently. And then therapies. We still need data from larger cohorts. In this group of patients, the 68 patients I told you about, we saw that most patients needed 2 medications when they had medications, and we're summarizing here data from patients. At least 50% of patients who took the drug had some improvements. So valproic acid was very high, clobazam was high, lamotrigine, Keppra, and Topamax. There have been clear benefits in very small number of patients, so in 5 patients or 7 patients, so it's not enough to really say if this should be first, later, how good it is. So we need more data. We need more data in the natural history evolution study, basically, to answer these. And of course, they all have different side effect profiles, so it's a question of what are the disease manifestation in your kid to better decide with the physician which drug to try. Ketogenic diet was very helpful in close to 40% of patients that used it, so that was interesting. Other dietary changes were tried, gluten-free, lactose-free, casein-free, with no clear benefit, but these are very small numbers. VNS, we clearly don't have enough data to conclude, so I can't say at this point. Maybe with the history study we'll know more. This was my last slide. So basically was this idea of future therapies, and we've heard that there is an interest to look for novel therapies. If we have less protein, at the roundtable, people were talking about various means, and as groups of scientists were thinking about means of enhancing expression of the wild type, preventing the degradation of the wild type allele, the normal allele, boosting the downstream signaling, and then targeting the circuit dysfunction. If the channel is too active, then channel blockers are interesting. And so we know that there are anecdotal evidence that verapamil may be useful. Verapamil blocks another channel. It's the L-type. It's the dendritic. It's the yellow spot that I can't point here on the screen. Anyways, so it's in the dendrites. It does seem to improve seizures for patients that have recurrent prolonged status epilepticus, but it may have other side effects that we still need more data to investigate in terms of perhaps in some children increasing the seizure frequency, but briefer seizures. Now, other means that are considered, antisense medication to try to block the mutation, blocking the downstream effectors, and targeting the circuit dysfunction. So last, just to say once again, from our data, we have evidence that with aging, perhaps the seizures are less frequent. So red is daily seizures, brown is weekly, yellow is monthly, and you can see that these are growing a little bit smaller as we grow. This may be reflecting the fact that we had less adult in the study, and so we need the timed information in the natural history to really know this with better data. So overall, thank you for the questions you've asked, for all of these videos, and please write me if I can answer other questions I haven't. Thank you.
Thank you. So Elsa and I will be around, and if you have questions, and we'll be happy to answer individually. So we're going to now move on to the hemiplegic migraine panel. I think, Irene, please.
So thank you so much for having me here. So I'm Irene de Boer. I'm a physician and a biomedical scientist from the Leiden University Medical Center from the Netherlands, so a long way from here. And I'll be giving this talk together with Alexis. And what we're going to do is we're going to give a short overview about hemiplegic migraine, and we try to incorporate as many questions as possible. But of course, there were a lot of questions, a lot of good questions, but we can't answer them all. But we're here all day, so feel free to come up to us at any time, and then we can discuss your questions if they're not answered in this presentation. So, short disclaimer, this presentation can be taken as medical advice because we don't have the specific situations. But again, if you have other questions, feel free to ask them. So I want to very quickly go over what hemiplegic migraine is. And one of the things that I want to point out first is that I put in adults into brackets. And that's because sometimes in children, it's much more difficult to get all these symptoms out of your child because they're not able to communicate it. So it can be quite challenging to make the diagnosis, even though I'm going to be very clear about what it is. So even we find it sometimes difficult. So hemiplegic migraine is a disorder where there's migraine. So that's a migrainous headache, which is very typical. And in combination with these patients often suffer from other complaints, which are the vocal auras. And these can be problems with vision, language difficulties, but also numbness or pin and needle effects. So these are all vocal neurological symptoms. But what makes it hemiplegic migraine is that these patients also have weakness. And this can be weakness that leads to them not being able to move a limb at all, but it can also be more subtle, the weakness. And that is what we call hemiplegic migraine. This disorder can be caused by several genes and can also be not caused by one of the genes. But what we're here for today is that it can be caused by COCNA1A. So we'll go into more detail about that. But before we do that, I want to give you a little bit more about the definition of this disorder. So hemiplegic migraine, we can divide that in two groups. And one of these is familial hemiplegic migraine, in which there is another family member who also has the disorder, which we were taught about earlier today. But you can also have sporadic hemiplegic migraine, in which the person is the first to get the disorder. And this is the case in many of the pediatric patients that we see. So often the mutation is de novo, so it starts with the patient, and they're the first that has the disorder. So these are the two types, and once COCNA1A is involved, we call them hemiplegic migraine 1. So when do you find a mutation in these patients? Well, what's important to take away from this slide is that when the disease is severe, it's much more likely that you'll find a mutation in the children or in the adults. And so if there's a severe hemiplegic migraine, for instance, because there's a lot of weakness or because there's swelling on the MRI, the chances that you will find a mutation become much, much higher. So what I would like you to remember from this slide is that COCNA1A hemiplegic migraine is often more severe than other types of hemiplegic migraine. Another thing that's important about this slide is the age of onset. Frequently, when it's due to a genetic cause, it occurs more earlier in the disease course. And that was actually one of the questions that were asked about, that we got from, can it occur later in life? Well, you can never say no, but when there's a COCNA1A mutation involved, it's much more likely that the hemiplegic migraine will occur while the child is still a child. So that's one of the things that I would like to give away from you. Another thing that's important is we talked a little about the definition, and that is that we're still working on these kind of definitions because we're learning more and more by the information that you are all providing us. And by this information, we learn more and we can use this information to make different groups. And we use this to distinguish mild hemiplegic migraine now from more severe hemiplegic migraine. And this is one of the things that we will be adding into the guideline, the clinical guideline, so that other physicians can use this as well. And one of the important things to notice here is that when we call it mild, it's when it's resolved within 72 hours, sorry, Dutch, and also when there's an absence of other features. So that's basically the main thing that I want you to take away from this slide. So if it's severe, then you have a very good treatment plan, and that's something that Alexis will talk about later. So very quickly, the genetics, you already heard a lot about this, and what was already mentioned, that it's usually those gain-of-function mutations that can lead to hemiplegic migraine. These are just a couple of examples, and because I couldn't help myself, the next slide will talk a little bit more about the pathophysiology of the disorder. Feel free to tune out, as it's almost lunch, but one slide. And what I want you to show here is that there is a mouse model for hemiplegic migraine, 2 actually. And what was done, was that a threshold stimulus test was done to see how much you need to test these mice before they start to develop the migraine. And this is actually what we can link towards our patients and how we believe this works. So we think that when you have hemiplegic migraine or another type of migraine, you're much closer to the threshold of developing this migraine. And you can see in these mouse models that that's actually true, that they're easily triggered. And these kind of tests can help us learn more about the pathogenesis of this disorder and can help us find treatments because we know where to aim for. So this is the slide where I just want to show you that Lina Lusk, which is unfortunately not here today, but this is her work together with Alexis and colleagues of hers, that they tried to see what kind of symptoms are associated with these hemiplegic migraines. And they did a lot of literature research, but also patients of their own. And they find that it's not just those migraines. For instance, you also see that there's fever associated with these attacks and other signs as well. So it can be challenging to make the right diagnosis, and sometimes a specialist needs to be consulted to get to where you need to be. So what's important, which was already mentioned, these signs can be variable among individuals, even with the same mutation, but also they can be variable within individuals. So when a person has a migraine attack, it doesn't always have to go the same way. And a question I already received from the audience here is, what is the link between hemiplegic migraine and common migraine? And it's important to realize that these patients with hemiplegic migraine also often have common migraine attacks, which can be migraine with aura, but also migraine without aura. So there seems to be a clear link between those two. So a little bit about treatment, and then I'm going to give the floor to Alexis, which is the preventive treatment, which is what I'll be talking about. And unfortunately, we don't have clinical trials, so we don't have clear proof of what is efficient. But what we do have is we have a lot of retrospective data, and we have case reports and case series, and by combining those, we can try to find treatments that can work. Unfortunately, this is still trial of error, so you have to try something and see if it works. But these kind of drugs, including acetazolamide and valproic acid, this is not ranked in which way this should be tried, but they can all be tried. They have shown some efficacy in hemiplegic migraine, so these are the kind of drugs that can be tried. For verapamil, it's important to realize that there's still a lot of work being done, and it's currently actively under investigation. It's a drug that was mentioned in the roundtable, so we are also discussing these kind of drugs which have been around for a long time to see how they can be refurbished. And then I would like to hand over the presentation to the next part, and then we'll have plenty of time, I hope, for questions if you're not too hungry yet.
Hello, everybody. Thank you so much for having me. My name is Alexis Karlin. Just to briefly introduce myself, I trained in pediatric neurology at Children's Hospital of Philadelphia, and then I completed a fellowship in epilepsy genetics. 2 years ago, I came to the CACNA1A Foundation conference, and in the course of my training and fellowship, I saw several patients with CACNA1A related disorders, including CACNA1A related hemiplegic migraine, and that really launched my interest in CACNA1A. I'm not currently at CHOP anymore. I actually moved to Israel, and I work at Schneider Medical Center in Petah Tikva in Israel now. So I'm just going to start speaking about some of the associated features that we see in CACNA1A in individuals with CACNA1A-related hemiplegic migraine. Similar to what we see in CACNA1A-related disorders overall, there's a great deal of variability in patients, and particularly with regard to associated features. So in terms of neurodevelopment, we see that patients range from having typical development to having developmental delays, which can be mild to severe. Some patients have autism as well, which again can range from mild functional impairment to severe functional impairment. We also see that there are some patients who have ataxia and/or other movement disorders, but again, this isn't sort of invariable among all patients with CACNA1A-related hemiplegic migraine, and the degree of severity can also vary. And then epilepsy is clearly a component of many patients who have CACNA1A-related hemiplegic migraine, but again, we don't see this in all patients. I'm not going to give any clear percentages right now. Probably around 25 to 50% of patients with hemiplegic migraine related to CACNA1A also have epilepsy in our pediatric population, but these numbers are really not clear and affected by ascertainment bias. That is, the people that come to see us generally have more severe disease. So in terms of epilepsy, again, sometimes epilepsy can be easily controlled. Other patients have very difficult to control epilepsy that's refractory to multiple medications. Some patients have never had a seizure, and some individuals with CACNA1A-related hemiplegic migraine only have seizures during hemiplegic migraine. And I think that's very important to point out. Sometimes those seizures during hemiplegic migraine can be status epilepticus, so very, very prolonged seizures. And sometimes those seizures can actually not be immediately clinically apparent, so they can actually be non-convulsive seizures that are really only easily recognizable on EEG. This is a very, very busy slide. I don't expect you to read through all of this, but I wanted to provide you with an example of our treatment guidelines. So this is basically a flowchart that is intended for physicians that takes them through the steps for diagnosis and clinical management of an acute hemiplegic migraine episode. The CACNA1A Foundation has done an incredible job in recruiting physicians to come up with treatment guidelines for CACNA1A-related disorders, and this is one part of our treatment guidelines. I'd like to point out that the mainstay of treatment of emergency treatment for hemiplegic migraine is very prompt recognition of and prevention of brain swelling or cerebral edema, as well as monitoring for and preventing or treating seizures in the most severe cases. So one question that's come up several times, and it's an excellent question, is what kind of language do we use to get medical staff who might not be familiar with hemiplegic migraine? How can we get them to recognize what this entity is? How can we make sure that they're treating our children appropriately if they've never heard of this disease before? I think it is important to recognize that while there is overlap between hemiplegic migraine and typical migraine, it is a very different entity. It should not be treated like a typical migraine, particularly because we do see that there's association with cerebral edema, again, or brain swelling in some cases. So we recommend basically having a hemiplegic migraine emergency action plan. So this includes language that tells physicians about the potential for severity, the potential for progression of this disorder, and provides instructions, basically the previous slide, in a letter format for how to treat and manage hemiplegic migraine, particularly if kind of the pieces aren't really adding up and if the patient isn't improving as we would expect. Which patients with CACNA1A variants should have this emergency rescue plan? Generally, we have an overabundance of caution when it comes to providing patients with an emergency rescue plan. So we would recommend all patients who are diagnosed in childhood with missense variants, because with missense variants, it's not always clear if this is going to be a clear gain of function or a loss of function. So again, with an overabundance of caution, we'd like to provide these emergency action plans to all patients, as well as any patient who's had suspicion for a hemiplegic migraine episode in the past. I am including here also kind of our sample emergency action plan that I developed at Children's Hospital of Philadelphia. Again, it includes language that highlights this is a potentially very severe or even life-threatening disorder, and it needs to be treated promptly. Part of our emergency action plan, as I'd like to emphasize to our audience, is that if a patient is having their first episode, or if a patient is having an atypical episode for them, they should present to the emergency room right away. I'd also like to point out that CACNA1A-related hemiplegic migraine in general, can masquerade as many other neurological disorders, and vice versa. So if things are really not making sense from a clinical standpoint, there should always be the consideration for additional workup, additional imaging, other studies including EEG. And so it's really important for both families and physicians to keep an open mind. So I wanted to address some of the questions that we received through the foundation. And again, if I'm not addressing all of your questions, feel free to come find us after as well. So one excellent question was, does CACNA1A have an effect on brain recovery after an injury? And I thought there were kind of two aspects to this question. So the first aspect is considering brain imaging after an event or kind of progression of the disease overall. So we have seen in some individuals with CACNA1A-related hemiplegic migraine, particularly with prolonged hemiplegic migraine that's associated with cerebral edema, or again, brain swelling, or recurrent hemiplegic migraine with cerebral edema, that these patients might eventually develop brain atrophy or decrease in brain volume on that side of, on the affected side. We do not see this in all cases, and we don't really have a great understanding of what kind of protective mechanisms there are or what mechanisms put patients at higher risk. The question is whether this is distinctly related to CACNA1A versus the hemiplegic migraine event itself, and the answer is we don't really know. We do see brain atrophy develop in other disorders with hemiplegic migraine, such as ATP1A2, but again, we don't have a good answer of whether the degree of brain atrophy is specifically related to CACNA1A or the hemiplegic migraine itself, the duration of hemiplegic migraine, and the degree of brain swelling. I think the other aspect of this question is some patients have a very prolonged recovery time after hemiplegic migraine, regardless of any imaging findings. So why do some individuals take a much longer time to recover after a hemiplegic migraine versus others who more rapidly recover? The answer, again, is we don't know. Again, it could be related to some degree of injury that occurs during the event. It also could be related to the patient's neurodevelopmental baseline. So that we have seen that in some patients with underlying autism, sometimes it can take them much longer to return to their functional baseline after an event. And again, that the reason is not, the pathophysiology behind that is not very clear. Okay. This, again, was a very good question. For a toddler with hypotonia and controlled epilepsy, how low or high is the risk for future status epilepticus or hemiplegic migraine? So again, the risk is hard to quantify. But again, I think there's two aspects to this question. One is looking at the genotype, and one is looking at the phenotype or the clinical presentation. So in terms of the genotype, overall, we know that loss of function variants tend to have a much lower risk for status epilepticus, a much lower risk, almost nearly a zero risk, as far as we can tell right now, for hemiplegic migraine. Again, gain of function variants have a much higher risk for both of these entities. In terms of the clinical phenotype of the patient, we also have seen that patients or individuals with seizure onset before the age of 2 do have a higher risk for developing hemiplegic migraine later in life. For those who are kind of in this less clear zone, the gray zone, it can be very unpredictable. Hemiplegic migraine in CACNA1A is a very unpredictable disease. For patients with controlled epilepsy, generally speaking, status epilepticus is rare. However, in patients with hemiplegic migraine, status epilepticus can co-occur with the hemiplegic migraine, and again, that can be unpredictable. Does a hemiplegic migraine always cause paralysis? So again, an excellent question. Per our definition, yes, hemiplegic migraine must cause some degree of weakness. However, in individuals that are under the age of 2, we have seen anecdotal reports of individuals who present with some degree of cognitive dysfunction, ranging from mild confusion to even outright coma. In individuals under the age of 2, any kind of weakness might not actually be clinically evident. So in retrospect, we believe that in individuals who later develop hemiplegic migraine, we believe that these events were probably hemiplegic migraines where the weakness was mild or not even clinically evident at all at that time. It's much rarer at older ages, so at this time we kind of, if there are presentations without weakness above the age of 2, it's much less likely to actually be a hemiplegic migraine. I think this is also a really important point because again, hemiplegic migraine can masquerade as different disorders. And so it's very important for physicians to keep CACNA1A related hemiplegic migraines sort of on their list of a differential diagnosis as a patient is undergoing a workup for encephalopathic events or events where they're confused and potentially comatose, particularly if kind of all of the other sort of workup is coming back negative. So up to this point, I've kind of been trying to avoid actually giving percentages, again, because a lot of our data is biased based on ascertainment bias, so that the patients that we're collecting are often more severe. We conducted sort of a retrospective study that we're still working on publishing, but we presented a poster at American Epilepsy Society where we looked at a cohort of over 450 patients, including patients from the literature with sort of variable detail in some of the very early studies. And then it also includes our own patients from 3 different sites. So in that cohort, which is retrospective, we found that about 27% of patients had hemiplegic migraine. That's individuals, not variants. So many of these individuals had recurrent variants, so the same variant. And then what percentage of CACNA1A variants cause epilepsy? That was about 40% in our study. And again, many of these were recurrent variants. The other point I'd like to make, which has been made before, is that we do see, even in recurrent variants, there's certain recurrent variants that we see a very high degree of similarity between patients. One of those, which you might know, is A713T. There are other variants where there's a great deal of variability still between patients. And some of what we believe has to do with that is probably polygenic risk, so other genes that confer risk or protection on those patients on different clinical symptoms. And part of that has to do with epigenetic or environmental factors. But this is, again, sort of the gray area of science. And so with that, I'd like to thank you all for your attention. I really would love to thank the CACNA1A Foundation and our 3 supermoms who are just incredible, and all of you all, patients and families.
I think, thank you for sending the questions ahead of time. I think we have time for maybe 1 or 2 questions. If you have any burning questions, please do ask. Anybody? Okay, here. 1, yeah.
How often do you see alternating hemiplegia purely without the migraine versus true hemiplegic migraines within CACNA1A, and how do you differentiate with the language barriers and the cognitive barriers with our kids? And then also, what are the psych symptoms that you're seeing in relation to hemiplegic migraines? Because I noticed on that slide it said psych symptoms at the bottom. And then how severe does the hemiplegia have to be to quantify it? Does that make sense? Can it just be foot drop? Does that make sense? How far do we have to go to qualify for treatment and to push for it? Does that make sense? Because we've gotten a lot of pushback from the medical community in regards to treating our son when he is symptomatic.
Do you want to answer that, Alexis? I think there's one that's working. So there's
Hello?
Yeah, go ahead.
Great, okay. So you had a lot of questions there. I might forget 1 or 2 of them, so please forgive me and you can remind me. So one of the questions, I should have a notebook here. One of the questions was, what are the psych symptoms? So psych symptoms can be variable. It can be irritability, it can be, so often in our children it would kind of be more about irritability, aggression during a hemiplegic migraine, which might reflect pain. Another question you had was kind of the degree of hemiplegia. So I think Irene can also speak to some of the different degrees of hemiplegia that we see in our patients, but it can again be variable. I'm going to get to your question about like treatment in a second, because the first part of your question was related to alternating hemiplegia. So that's actually a different. It's a different disorder. So there's a disorder called alternating hemiplegia of childhood, which we see in ATP1A3 primarily, not to be confused with ATP1A2. But that's really a different disorder. And although they can look similar clinically, they're mechanistically and clinically different. So if you have a diagnosis of CACNO1A, then we would kind of put the stamp of hemiplegic migraine. In terms of treatment, again, I think there's a preventive component and a sort of acute abortive component of treatment. So preventive-wise, this is kind of highlighted in our treatment guidelines, but we have pretty clear guidelines for when to start preventative treatment, and it has to do with the frequency of events and the degree of severity. So even if you have like one extremely severe event once a year that lands you in the ICU, well, you qualify for preventative treatment. If you have kind of less severe events but more frequent, again, you could qualify for preventative treatment. In terms of our emergency action plan, there are some treatments that we recommend to administer at home as an emergency medication at home at the onset, like as close to the onset as possible of the event. And if the disease then progresses, then you would kind of present to the emergency room, depending again on sort of the severity. So we sort of stratify our recommendations based on the severity of the patient's progression and associated signs and symptoms, including imaging. I hope that helped to answer. Did you have anything to add?
I think that was basically the answer, but just to add about the alternating hemiplegia of childhood, it can be very tricky. So indeed what Alexis said, based on the genetic diagnosis, you go one way or the other, but it can be very difficult, especially in those children that are not able to communicate or are too small to be able to examine them well enough. So it can be very challenging, especially if there is not a clear genetic diagnosis, if a fuss is found. Then it becomes very confusing. So
all right, we have a hard stop at 12:30, so we have one more question, and I think we'll go for, it's okay? Yeah, okay.
Sorry, I was just wondering, can HM be commonly associated with triggers the way we think about seizures having triggers?
So one of the important triggers is head trauma. So that's the most important one. Head trauma, that's very, very important. So if patients that play sports with a ball or something, they're at risk. So that's something to consider. Other triggers, like for instance, sleep deprivation, is still being studied. So there are signs that this is important, but it's not that we have a clear answer on that yet. But we do think there is a role for that.
I'd love to have you come to the podium to ask questions individually. I think we have to go for lunch. Have a wonderful lunch.